Hi everyone. Thank you so much for being patient. We wanted to make sure everyone got here with traffic and all that kind of good stuff. That's the thing about evening forums. You have to fight with rush hour. So thank you for being patient. And thank you so much for coming to this year's medical forum on how to ask questions to your doctor. We're really fortunate to have Dr. Andrews here this evening. I know many of you sent in questions, and there'll be time at the end also to ask other questions to her. But let me just give Dr. Andrews an introduction, and then we'll get started. Dr. Andrews is an attending physician at North Shore LIJ Cancer Institute. Can you get closer to the mic? Sure. Is this better? Yeah. Okay. For future reference, we have to be closer. She is also a clinical professor at Hofstra North Shore University. She's an advocate for patients who is concerned about disparities in medicine and oncology. Dr. Andrews also founded Kicked It in Heels, a nonprofit organization dedicated to ending healthcare disparities with women and breast cancer. So let's give her a nice warm welcome.
Thank you all so much for coming. I'm typically pretty loud, but let me know if it's not loud enough.
A little bit louder.
A little bit louder?
Please.
Better?
Yes.
Okay. Just flag me, okay? So this is my second year speaking at this forum, and I'm extremely grateful to be invited back. I think that these discussions are so important. I think just having the dialogue and being able to ask questions is imperative to understanding your diagnosis and or a loved one's diagnosis. That being said, when Erin asked me to give this talk, she really didn't want me to talk about radiation oncology. So I'm happy to talk about what should I ask, but just be gentle with me because I have not given this talk before, and pretty much what it is the questions that I get asked when I'm in the room with my patients, the things that kind of aren't necessarily in the textbooks or what have you, things that are evolving in breast cancer as we speak. So I'm gonna go through my list of what I think maybe you wanna know, and then at the end, jump in, let's start talking. I'll answer what I can. Again, I'm a radiation oncologist, not a medical oncologist, so go easy on me. All right, let's get started. So what should I ask? And I should preface this by saying I was actually the breast cancer specialist at Indiana University, and prior to that, my fellowship had actually been in prostate cancer. So most of my experience had been with men, and there's a night and day difference between how men handle their diseases and how women handle their diseases. And what I found, it was extremely rewarding. I loved working with women as a population, but what I found was that women will do what they have to do, right? They're the caregivers for their family. They are taking care of their husbands, their children. They are not going to miss a beat. They will get through their cancer treatment. A lot of what I saw was that once women were done with their treatment, they did skip a beat sometimes. They didn't necessarily feel like themselves. They didn't feel beautiful. They didn't feel sexual. To me, there was a lot of emotional and psychological things that were going on that we don't necessarily address. So I do talk about that at the end of my discussion, but that is probably where my passion lies, but let's go ahead and get started. So how many of you know about white coat syndrome? All of you. White coats. I love it, an educated audience. So, any visit to the doctor's office can be intimidating. I mean, I don't like going to my doctor, right? I mean, I'm probably the worst patient there is. But that being said, there are some people that going to the doctor just makes them extremely anxious. Their blood pressure goes up. They actually have a physiologic response to going to the doctor. And so ultimately, they probably just don't go. Or they go crying like this little baby. There is actually a fear of going to doctors or a phobia of doctors called iatrophobia, and it's actually a common mental disorder. Typically probably brought about by either a traumatic event that you or a loved one has had with a doctor, You may be intimidated by physicians. A lot of people feel like doctors are emotionally unavailable. Potentially a prior serious illness that you watched a loved one go through that left a bad impression, or for your own personal reasons, you're just afraid of a negative outcome. The phobia is common, and anxiety is normal, but what you want to do is distinguish anxiety from a phobia. So it's okay if you're anxious about going to the doctor, but you still need to get up and you need to go. We all do. If you have a phobia, there are treatments that you should seek and speak to an actual professional about working past this, because what we will say in medicine, just in general, is that prevention is key. So we'll say that in medicine, and then we'll emphasize that for cancer, right? If you can prevent it, if you can live a lifestyle that potentially decreases your risk of developing cancer, if you can go through your screening mechanisms that decrease your risk of having cancer, you're one more step ahead of the game. So the first question I always get asked is, should I change my diet? And I was at UCSF when Dean Ornish was actually publishing a lot of his diet books on prostate cancer. And so I've been watching this and reading about this for a long time. And so I can honestly say that I've read Sugar Busters, I've read, the macrobiotic diet. I see my patients come in on all different sorts of diets, and I never knock it. But what I do say is that in all likelihood, changing your diet to one of these more extreme diets does not necessarily improve your outcome. You may feel better, especially if you previously had a diet that was higher in processed foods. You probably are healthier as long as it's a balanced diet, but ultimately the ideal diet is just a well-balanced diet that's low in fat. That being said, what is the ideal diet? So US News and Reports in 2015 actually came out with a nice list of best diets. So best diets for heart health, best diets for just overall health, best diets if you're trying to lose weight. So I can't ever tell you what's the best diet for you. I just want you to eat well and be healthy. But if you're looking for actual specific diets, they actually rank them. So depending on what your goal is, I would check out this report and see if there's anything that calls to you. When you're looking at a diet, though, make sure it's something that you can sustain and not just a fad. Make sure that it's something that you can sustain as a lifestyle. Ultimately, regardless of your diet, you need to choose to live healthy. And I tell my patients, I have some patients in the room, I make sure my patients are exercising, I make sure my patients are eating their vegetables, because we know that obesity is linked to cancer. So obesity is linked to colon cancer, it's linked to breast cancer, endometrial cancer, pancreatic cancer, cervical cancer. The list goes on. There is a direct relationship between obesity and these different cancers. And yes, losing weight does potentially reduce your risk of cancer, but ideally you want to just try to maintain your ideal body weight throughout your life, which is easier said than done, certainly, but you don't want to be underweight either, because that causes a whole nother set of problems. That being said, this is not about how you look, this is about being fit and being healthy, and so you really want to make sure that you're realistic when you are considering your weight, and you don't want to buy into any unreasonable media creations of the ideal. So this is a nice picture of Kim Kardashian, and the picture closest to me is the original picture, and then the picture on the left is the airbrush picture. And I don't know how many of you have Photoshop on your computer or a photographer that's willing to airbrush all your pictures, but this is not realistic, and you just have to keep that in consideration when you're comparing yourself to the ideals that the media has put in front of us. Certainly I'm not trying to take the joy out of life, but we do have to watch how much we're drinking, and I think we're a pretty social group, and so we probably all like a glass of wine here or there, but for women, you really want to make sure that you're not drinking more than 1 drink a day. For men, ideally, you don't want to drink more than 2 drinks a day. And you always want to make sure that you're maintaining some sort of moderate level of physical activity. So when I am harassing my patients and asking them if they're exercising or if they're physically active, certainly I'm not encouraging them to go out and run a marathon. I'm happy if they walk around the block. I'm happy if they walk around the block 5 times. And I actually created this slide before I got my own Fitbit, so this is not a commercial for Fitbit, but I have to say that it is helpful, just as a reminder that you actually need to get up and move. It does keep me more active than what I would normally be. I like this picture because it's actually from the 1981 New York City Marathon, so I think it's a great picture. But no, you don't have to run a marathon, but what you do have to do is try to get at least 150 minutes of moderate intensity activity or 75 minutes of vigorous intense activity per week. And that's in addition to your normal daily activities. So it's not you going to the grocery store, it's not you picking up the kids. You actually need to have a good amount of time where you're getting your heart rate elevated and is dedicated to actual physical activity. For those of us that have demanding jobs and try to save all their workouts to the weekend, this is no good either. Weekend warriors, this is what we all thought we were doing, just saving our workouts for the weekend, apparently is not good enough either because you are not spreading out the activity. So it's not okay to work out for 5 hours on a Saturday and think that you have offset the 8 hours that you spent every day sitting down. So essentially you just want to limit your sedentary behavior. So another question that I always get is, can I have a drink? And I always say yes. But the fact is, most of my patients will tell me I only drink wine, and it just doesn't matter. Alcohol is alcohol. So whether you're drinking wine, whether you're drinking cognac or a wine cooler, they all have a risk of increasing your risk of cancer. You just need to be cognizant about the decisions you're making. Let's talk about genetically modified foods versus organic foods. So what I think is interesting about genetically modified organisms is that I'm starting to see more and more labels on foods that do have GMOs or do contain GMOs. But basically what they are bioengineered foods that have had genes added either to help increase the growth, to slow spoilage, potentially to enhance the flavor. And the overall consensus at this time is that GMOs are safe. That being said, most countries actually require that you put a label on foods that do contain GMOs, and for whatever reason, the United States has not taken that leap just yet, and it's actually very controversial if you look at the literature. But at this point in time, GMOs are safe. Let's talk about organic foods. So farmers that grow organic produce typically don't utilize traditional methods to fertilize or weed their crops. What they're trying to do is promote sustainable practices that will promote longevity, productivity, without affecting the bio-ecosystem, essentially. And the U.S. Department of Agriculture has established an organic certification program that requires all organic foods to meet strict government standards. So it's not, if it says natural, it's not organic. Organic and natural are not the same thing. Organic actually has to go and meet certain criteria for it to be labeled as organic. That being said, as much as I love going to Whole Foods because it makes me feel better, there's no clear evidence that organic is more nutritious. And the downside to organic, especially if you're feeding a family, is potentially it's just very expensive. What about supplements? My patients always ask me what vitamins they can take, or they're coming in with a long list of vitamins. Supplements, I think, are fine. I don't think there's any concrete evidence on supplements. What we will say is that supplements cannot take the place of a healthy, well-balanced diet. So if you don't like your vegetables, it's not enough that you then take supplements to try to offset that. There's no evidence that taking supplements can actually decrease your risk of developing cancer. And in February 2014, the U.S. task force actually demonstrated that they couldn't show that there was a harm or benefit to taking supplements in terms of trying to prevent heart disease or cancer. The two exceptions to that were vitamin E and beta carotene, and they were recommending against it. What about probiotics? For a long time, I kept watching those Activia commercials, and I was just confused. I was like, is it just normal yogurt? I don't get it. So I was very ignorant about probiotics. Basically, probiotics are live microorganisms that suppress the growth of bacteria that can support cancer-causing agents. They are important essentially because they help to strengthen the immune system. And if you strengthen the immune system, the body is able to fight off infection much easier and much better. Hepatitis B, hepatitis C, Helicobacter pylori, HPV, these are the most 4 common infections that are known to cause cancer, and combined, they cause about 2 million cancers a year. What probiotics do, since they're able to help the body fight the infection, they basically help the immune system fight developing cancer. We know that they're particularly effective in reducing vaginal and urinary infections. And again, if the gut is full of healthy bacteria, it can expel waste and toxins much easier. So now let's talk about smoking. So while I guess I'm a bit of a hypocrite because I'm okay with my patients having a glass of wine or a cocktail, I will harass you endlessly to try to get you to stop smoking. We do all have our vices, but there are certain vices that we know are just truly detrimental. And so smoking is one of those. We know that it causes cancer, heart disease, diabetes, stroke. Smoking increases your risk of any of these different diseases. And at this point in time, as Big Tobacco tries to encourage more young smokers, they don't have the same excuse as the older generations that didn't have the Surgeon General's warning on the package. So we now know what smoking does, and it's a conscious decision if you do decide to smoke. But on average, smokers die a good 10 years earlier than the rest of the population. And they now have those commercials where they show the effects of smoking, which I think are very graphic, but I think they're also very helpful. So smoking is the leading cause of cancer and is the leading cause of cancer death. Again, there's a direct link between smoking and head and neck cancer, smoking and bladder cancer, esophageal cancer. Essentially, if you are a smoker, you're 25 times more likely to develop lung cancer. And when you look at the agents that you can find in cigarettes, due to the additives that they treat tobacco with, there are at least 70 cancer-causing agents in tobacco. And these are just the ones that the companies have admitted to. They haven't admitted to all of them. But carbon monoxide, arsenic, hydrogen cyanide, you wouldn't necessarily willingly put these in your body, but I recognize that tobacco is an addiction. If you become addicted, it's not as easy to keep this in perspective. However, there's always hope, and so if you do quit smoking, you basically drop the risk by about 50% of you developing head and neck cancer, esophageal cancer, bladder cancer. Your lungs will forgive you as well. So if you quit smoking, I think within 10 years after you quit smoking, the risk of developing lung cancer will drop by 50% as well. Now, I actually just gave a talk down in Florida, and this question surprised me because it was a very conservative crowd, but what they wanted to know was, what are the effects of marijuana, and does marijuana actually increase your risk of developing cancer as well? I'd be lying if I said I'm an expert on this topic, but I did try to do my research. There really isn't a lot of data on it. Certainly marijuana is not treated the same way as tobacco with the additives or what have you, but you don't know where the marijuana has been grown, so it's not like it's organic marijuana. You just have no idea. We do know that marijuana medically can help with nausea and vomiting and different chemotherapy symptoms. But that being said, we also know that if you inhale marijuana, there is association with testicular, prostate, and cervical cancer. I don't know if that's a cumulative effect in terms of how many marijuana cigarettes you have to smoke. That I don't know. So those are all the things that we can control, right? Our diet, our exercise, what we're inhaling, what we're eating, what we're putting in our bodies. But in terms of prevention, we know that screening is essential. I also think in terms of prevention, you just have to ask questions. You have to know your own family's history, and then you have to ask your doctor what your risks are, basically. So recommended screening tests include mammography, colonoscopy, pap smears. The lung cancer screening trial actually found that Low-dose CTs were effective for screening high-risk smoking populations, and prostate cancer screening, which has now become a little bit controversial. So for women over the age of 40, mammography is recommended unless you have a first-degree relative that was diagnosed younger, then potentially you may want to start younger as well. For colon cancer, thankfully, we have over 1 million survivors of colon cancer, but that being said, 1 out of 20 people will develop colon cancer. You want to start getting your colonoscopies by the age of 50, again, unless you have a family history, because 1 out of 5 diagnosed will also have a family member that's affected. Cervical cancer, typically start screening for cervical cancer around the age of 21. By the time you're 30, they're not just doing pap smears, they're also testing for HPV, which was one of the viruses I listed before. By the time you're 65, if you are not sexually active, you probably don't need to get screened as much. If you've had several negative screening pap smears, potentially you don't need to screen any further. And again, the low-dose CT screening, this is relatively new, but what they found is in high-risk populations, patients that have smoked for greater than 20 years or smoking 2 packs a day, what have you, they found a lot more early-stage lung cancers than when they tried to screen these patients with x-rays. So why am I talking about iatrophobia? Why am I talking about white coat syndrome? For me as a physician, these are the things I see that potentially delay diagnosis, right? The fear of going to the doctor, the fear of getting the diagnosis of cancer, or even pursuing preventative measures. When I talk to my patients, particularly the ones that came in late for their diagnosis, these are the reasons why they don't want to come in. So let's talk about a case, and let me get your thoughts on this. But we have Karen, who's an African-American female. She's 62 years old, and she was diagnosed with a stage 2A, T1N1 invasive ductal carcinoma of the left breast. The plan is to treat her with a left partial mastectomy, with sentinel lymph node biopsy. The patient is not a candidate for chemotherapy because she has renal insufficiency, but she will need adjuvant external beam radiation. How was that for you? Did you understand it? It's not understandable, right? It's medical jargon, it's medical language, and the fact of the matter is, not everyone understands medical jargon, and your physician should always keep in mind that we have to communicate with the patient that's in front of us. It is our job to make sure that when we're communicating with you, that you leave completely understanding your disease, and if you don't, then we need to spend more time. But we certainly shouldn't be speaking to you in our language, so to speak. So if we break it down and we say, Karen has early stage breast cancer that needs to be removed and her lymph nodes will need to be examined. Karen can decide whether to have her whole breast removed or just the tumor. And if she does want to keep her breast, then she'll have to have additional radiation, basically as extra added insurance to keep the cancer from coming back. Because Karen's kidneys do not function properly, she may not be healthy enough to have chemotherapy. Is that better? That's how we should be speaking to you. And when you've been diagnosed with cancer, I'm sure at that point in time you're completely overwhelmed and you have no idea how to navigate the system necessarily. You have no idea what doctors you need to see, in what order you should be seeing them. Are your doctors communicating with each other? And so what a lot of centers have done, formally or informally, is to start patient navigator systems, where essentially you are assigned, somebody is specifically assigned to you to make sure that you are, 1, they're making all of your appointments, 2, they're actually answering your questions because you don't necessarily always want to ask the doctor. Essentially, I find them invaluable. I've been working with patient navigators since I was at Indiana University, and for me, you see a lot less loss of patients, a lot less patients falling through the cracks because the patients feel more fully engaged in their care. Specifically for the cancer patient, I think with the patient navigator as well as community-centric efforts like this, I think it makes all the difference, because it's basically creating an environment that is potentially nurturing, and if not nurturing, that may not be what you're looking for. It's potentially at least less intimidating for you to ask your questions and to voice your concerns and your fears. So patient navigators can address all sorts of barriers between unemployment, transportation, childcare, literacy, language, but ultimately between patient navigators and physicians being more cognizant of health literacy and how they're speaking to their patients, I think we're making great strides in people understanding their diseases and why we are offering the different treatment options that we're offering. So let's move on. So this is the million-dollar question. This is what you don't want to hear. Your physician has just told you that you have cancer, and your physician is now going on about your treatment options and what doctors you need to see and what screening studies you'll need, and you are probably still stuck at the moment that your physician told you had cancer. So how do you process that information? You just heard something that you ultimately don't want to hear, and you have to move forward. And so what I find for a lot of my patients is they do move forward. They move forward whether or not they're afraid or not, but they haven't processed the information. And so what I always say is stay present, potentially bring somebody else with you if that's helpful. Ask questions, stop your doctor. If it sounds like a foreign language, like the 2 slides I presented before, stop them. It's not that the doctor is intentionally trying to make sure that you aren't understanding he or she. They are just probably used to either speaking to their colleagues or just not paying attention. But it certainly is not intentional, because for all of us, what we wanted to do is make sure that you fully understand your illness and what your options are. So it's critical that you ask questions. So a lot of times I'll meet a patient and I'll potentially probably be the 3rd or 4th physician that they've seen, and most of them don't necessarily know what their stage is. There is information that you need to know that will empower you. So you want to know what your stage is. You want to know what your treatment will entail, potentially how it will change your life or your relationships. Will it affect your children? And it's, at the end of the day, what you really want to know is, will your life return to normal after this? So stage basically takes the tumor size, nodal involvement, and disease spread into consideration. The stages run typically from 1 to 4, and so 1 is a much earlier stage disease. Stage 4 is a disease that's probably spread to other areas of the body. The larger your tumor, the higher the stage, and if lymph nodes are involved, potentially the higher the stage in that as well. When your physician is discussing your treatment options, you'll have friends and you'll have family, and they'll tell you what their treatments were. And just what you need to keep in mind is that your breast cancer is not the same as anyone else's breast cancer. And so the general treatment options are surgery, radiation, chemotherapy, hormonal therapy, and potentially reconstruction. But that being said, it has to be an individualized, personalized approach, and one person's experience won't necessarily be your experience, especially if they had a bad experience. So in the toolkit, we have surgery, which entails removing the tumor. We have chemotherapy, which is a systemic treatment that goes throughout the whole entire body to attack the cells. Radiation is a local treatment that directly targets areas of cancer, although in breast cancer, we are actually using radiation to target any potential microscopic disease that's been left behind. And then hormonal therapy essentially blocks estrogen activity. It's different for everyone. Everyone has to weigh their own personal benefits and risks. There's no right answer. I've never been upset with a patient for making a decision not to receive radiation or not to receive hormonal therapy. I feel like as long as that patient has been given as much information as possible, they are making a well-informed decision, and it just has to be right for them. So if it's breast cancer, you're meeting with your surgeon. Typically, you're trying to decide what type of surgery is right for you. What are the limitations of the surgery? Will it require reconstruction? What's the amount of recovery time? I did say you should bring family with you, but when it comes time to make your decision, you should make a decision that's organic to you, because your family will have all sorts of ideas that they feel are best for you, but potentially may not be, not intentionally. A lot of times what I'll see is a patient come in with their daughter, and the patient wants a breast reconstruction, and the daughter doesn't want the mom to have a reconstruction, which I find it fascinating. So if you are uncertain, seek a second opinion, and don't feel guilty about this. We do not take it personally. Most physicians would rather you do your due diligence and come to terms completely with what you're dealing with than to go into anything unclear as to why we're doing it. It's interesting because I would say fewer than 1/3 of patients actually seek a second opinion, and I think a lot of that is because the patient is afraid to offend their physician. But this is your life. So if the diagnosis is inconclusive, meaning the pathologist did a biopsy and the pathologist can't tell you if your cancer is coming from one area of the body or another, that's a reason to get a second opinion. If you have a disease that is life-threatening, that's a reason to get a second opinion, just because you want to make sure that all options are being put on the table. If there are multiple treatment recommendations and none are necessarily better than the other, or they're not making sense to you, get a second opinion. And if you're considering enrolling on a trial, that's a good reason to get a second opinion. At the end of the day, the bottom line is you should not feel guilty. This is your life. You have to do what's best for you. Let's talk about some of the side effects from surgery. So a few years ago, I actually tried to submit a paper on lymphedema, and it was so challenging to get that paper published. I really didn't understand why. I think lymphedema is one of those topics that's just really poorly researched and potentially not well discussed. Essentially what lymphedema is generalized swelling of the extremities. So if you're a breast cancer survivor, it's swelling of the upper extremities. The gold standard for diagnosing lymphedema is volume displacement. There are some studies now looking at whether or not bioimpedance is better to assess body composition, and that would be basically where you're using electrical pulses to assess the body composition. The studies at this time have not shown one to be better than the other, so I still say that volume displacement is the gold standard. Typically, lymphedema is caused after injury to the lymphatic vessels, and it can be frequently seen after lymph node dissection, plus or minus radiation therapy. Unfortunately, lymphedema can develop months to years after the procedure, so it's something you always want to be cognizant of. There's nothing that can predict whether or not it will occur. Some symptoms include heaviness, tightness, decreased flexibility, puffiness, and as I stated before, it's just really not well researched and not necessarily well received. I do see that it's changing. I do see more articles on lymphedema now than I did 10 years ago. But that being said, it's challenging. If you feel like your arm is puffy, if you feel like your hands are puffy, you want to seek treatment immediately. You want to try to reverse the lymphedema as much as possible. The 80% will have an onset of lymphedema within the first 3 years. But you can see from my ranges where I say the overall incidence is between 8 to 56% 2 years post-surgery. That's from pulling a lot of data. So the data is really kind of all over the place and also subjective to the surgeon that submitted it. What I can say is with sentinel lymph node dissection, you definitely do see a decrease in lymphedema compared to actually lymph node dissection, where the rate is approximately 20%. With sentinel lymph node dissection, where they're basically just looking at the first echelon of draining lymph nodes, taking 2 or 3 lymph nodes, there's definitely less risk of developing lymphedema. So you are now a survivor. You've gone through your treatment. You came out better for it, and now you have to heal mentally, emotionally, physically, sexually. What a lot of women are concerned about is once they're in survivorship, will their lives return to normal? And if you look at the data on survivorship, the majority of long-term cancer survivors which is growing every year, would say that their lives are comparable to prior to their diagnosis. They do feel like they're able to move on with their lives. The fear of recurrence becomes less and less as more time has passed from your actual diagnosis. There are certain predictors that will predict future quality of life, such as age, race, socioeconomic status. So younger patients tend to have poor emotional functioning, and depending on the age of diagnosis, that may be a young woman who is still in the childbearing years and potentially didn't have children, or is trying to decide what to do with her eggs. There are just additional issues that come when you're a younger woman facing this disease. Minorities and patients of lower socioeconomic status tend to have poor physical functioning, and that may potentially be cultural. There may be less of a support system there. I'm not guessing. Well, what I do notice, and probably what isn't discussed, is that 20 to 30% of breast cancer patients will have some form of sexual dysfunction. The influence on sexuality, unfortunately, has been shown to be persistent for greater than 5 years. This data is pretty old, right? It's from 2008. There's newer data from 2007 that says that sexual morbidity or the impact that breast cancer has had on your sexuality is, I guess, more influenced by mastectomy, women who have had mastectomies, or if you gained weight after your treatment. The fact of the matter is, a lot of women associate their breasts with sexuality, and depending on the surgery that you had, or just how you see yourself and how you view yourself, certainly it can make it and take an impact on your relationships, and as well as your own physical well-being in terms of how you see yourself. If you compare women who have not had breast cancer to breast cancer survivors, there's a difference in desire, there's a difference in the ability to orgasm, there's a difference in sexual satisfaction, there's a difference in pain, and it's not in their heads. I think that your body goes through all sorts of changes, whatever the treatment is that you had to receive, and you just have to be really kind to yourself and applaud yourself that you've gotten through this, and know that if you are at least willing to potentially have the conversation with your loved one or your physician, you're one step closer to getting beyond this with the sexual dysfunction. Another question that I often get is centered around racial disparities. When I did my training, I trained at Emory, and the beauty of training at Emory was that we actually had about 4 or 5 hospitals that we rotated through. So we rotated at the VA, we rotated at Grady, which is the county hospital, and then we had 2 very plush private hospitals. So to me, there's no better way to see disparities than when you compare a county hospital to a private hospital. The CDC actually published this data maybe about 2 or 3 years ago, and basically what they found was that although Black women have lower incidence rates of breast cancer, they actually have higher breast cancer death rates. And I applaud the CDC for doing this study, because the only way for disparities to end is to acknowledge that they do exist. Although Black women were doing better when compared to their peers, Caucasian women, Asian women, in terms of getting their mammograms, there was a significant disparity in terms of them actually getting diagnosed. So they were getting their mammograms, but it was taking longer between them having an abnormal mammogram to actually getting a diagnosis. So they would have the mammogram, but it would potentially take over 60 days for them to actually get the diagnosis of having the biopsy and then finding out what their disease was. So the study found that while, for example, 20% of women had Black women had diagnostic intervals over 60 days compared to 12% of women. And those types of differences play out in survival. Also, I'd say that many of the Black women were presenting with later stage disease. And cultural nuances, I think, come into play. But that being said, in my humble opinion, when we implemented patient navigation, it made a world of difference, because we were able to stay on top of patients that might have otherwise disappeared, either out of fear, intimidation, or denial. get a lot of questions about the Braf mutation. Basically, it's a hereditary mutation that increases the risk not only of breast cancer, but of ovarian cancer. Only about 5 to 10% of the population actually has this mutation, and it's highest in the Ashkenazi Jewish population. But if you have the BRCA mutation, you're 5 times higher to develop breast cancer, and you're 10 to 30 times more likely to develop ovarian cancer. It is daunting, and it is certainly overwhelming because you can't control your family, you can't control your family genetics or your history, but certainly knowledge is power, and if you know what your family's history is or you know what your genetic predilection is, you can then make a decision, whatever decision is right for you. So you want to think about getting tested if you had at least two family members in your family that have had breast cancer. If somebody was young, under the age of 45, when they were diagnosed with breast cancer, a lot of times we leave out men being diagnosed with breast cancer, but that does happen as well. If you have a family member that had a BRCA mutation, these are all the reasons that you want to think about, consider getting tested. And I think that is about it for me in terms of my compilation of questions that I get. I'm just going to come sit down so we can chat. Can I take this microphone with me?
Yeah.
Not this one. This one.
That one's for the box. Okay.
Okay. Do I have to call on people, or do you want to just start shouting out your questions? I was told that I should pick on the back rows. By the front row, Mike. So can I ask how many survivors there are in the room? Absolutely wonderful.
I think you should add to that warriors, because some of us are still in the fight
That's right.
and have been in the fight. I'm a warrior.
I think you're all warriors. No, absolutely.
I thought you were terrific.
Thank you.
I just wanted to say that.
You can say that when we get all here.
I thought you were terrific.
Thank you.
Super informative. And I'm hungry, I'm gonna leave now, so please don't get mad.
Thank you, because I actually haven't given this talk before, and so as I was putting it together, it just, I wanted to get all the questions in as much as I could address, but try to keep it somewhat, in order.
What I want to know is, how do you start? I was just diagnosed this week, and I don't know what to do.
And when you went, did you have somebody that was with you?
Yeah, my husband.
So I think, just to share a little bit about my own background, my mother is a breast cancer survivor, breast cancer warrior. And so I got to watch my mother go through it. So I'm not just speaking to you from the physician's perspective. It was actually a very humbling experience to watch one of my own loved ones go through breast cancer. And what I can say between my years of experience and watching my mother is you just get up every day and you put one foot in front of the other. Try to walk forward without fear. Get all the information, and then you and your husband sit down and you talk it out amongst yourselves and you decide what's the best way for you to proceed. Don't beat yourself up. Don't get upset with yourself for crying. Don't get upset with yourself for being angry. These are all the emotions that if you don't go through now, you will go through eventually.
But I think the question that I have is, okay, so I was called by the radiology office to tell me that it is. And so I went to a breast specialist. Where do I go from there? She's not, you then have to go to an oncologist as well.
So the breast specialist was a surgeon, the breast specialist?
Yeah.
And so the breast specialist typically will outline for you what your treatment options are. And depending on how they've diagnosed you and staged you, then you may potentially need radiation therapy, chemotherapy. It's a group decision. So you have to decide whether or not you want a mastectomy versus a lumpectomy, and then kind of go down those different paths. And typically, what I think is great is that I do think from mammogram to diagnosis, I think most of these institutions have done a tremendous job at getting women in, getting the diagnosis, and getting you started. But as I said before, I do see a lot of times that you don't necessarily have time to process, right? We're going to tell you what to do. We're going to tell you you need this, this, and this, and you just move forward because you don't know what else to do. So I would just say rely on the support of your loved ones, but typically the breast cancer specialist, the surgeon, will then refer you to oncologists that they work with, that they trust, that they feel they value their judgment. Certainly you can always lean on your friends and other support systems, but I would start there. I would start with all your different appointments, and then I would just put all that information together.
Can I also add that the
Oh,
program
yes. I'm
here,
sorry.
has social workers, and also we have 100 volunteers for survivors who've been there and who talk you through it. So please call us and we will help you.
I'm with my sister here. I just, forgive me, I'm leading to death.
I know, I'm sorry. I'm sorry, I hope you're okay.
I'm probably need stitches, but I'm here with her. I'm a great support, let me tell you. So, does she need to also go to the OBGYN and have her ovaries and everything else checked at the same time? I know everything's kind of linked. I'm just concerned.
I would say just process one issue at a time.
Okay.
Not saying it's not potentially going to come up in the future, you just don't know, but let's just process what's in front of you right now and get past that hurdle. You don't want to put too many fear-causing, anxiety-causing issues on the table at once. You tend to get just stuck in fear.
All right, I have two questions. Okay. One is regarding something you said in regards to getting a second opinion. And you said something about consideration in enrolling in the trial. Right. Now, what do you mean by that?
So I think that I won't get on my disparities high horse, but I think that you can look back at the history of medicine and you can certainly see where enrolling in trials weren't necessarily to the benefit of the patient, and so that creates a lot of distrust of the medical community. So enrolling in clinical trials is imperative to us pushing our practice forward in terms of us finding new drugs, finding new treatment modalities, what have you. But there's oftentimes a lot of distrust around clinical trials. I have patients that I think thoroughly trust me, but when I introduce the topic of a clinical trial, it raises quite a few hackles. And so I say, you know, if you're thinking about enrolling in a clinical trial, potentially get a second opinion of somebody that's not offering that clinical trial, just so you feel like you're getting an unbiased, objective treatment recommendation.
And I also have a question regarding to an IM that I got from somebody. Okay. And one thing that disturbs me is when somebody who isn't even going through what I went through has all the advice, have this, eat that, drink this, and I just want to know about this soursop. What is that? It's called soursop. It's a Caribbean fruit.
Oh,
it's Guyabano fruit and noni. I'm sure you're a noni fruit. Everybody's heard of that. And I'm being told that the FDA has tested this fruit, saying that it's supposed to help eliminate and fight cancer. Have you heard anything?
Or breast cancer.
Well, according to this person, that their grandmother had 2 bouts of cancer. She had intestinal cancer, and then she had breast cancer. So I don't take advice like that from anybody. I'm just asking in general. But, you know, I do what I have to do, and I try to eat as healthy as I can and be in the best positive spiritual
Absolutely.
So,
I think when your friends are offering advice, that's their way of showing you some love. And granted, it's not always asked for or appreciated, certainly, but I think people often don't know what to say, and so you'll see people that you love just kind of keep their distance, and then you'll see other people kind of impose themselves and maybe get a little bit too personal. I don't know anything about soursop. One of my best friends is Jamaican, so I have heard of it. In terms of FDA approval, I'm not familiar. I'll be honest, I'm not familiar. I'd be surprised if it was FDA approved. What you can do is go to you can go to the Adelphi website, and certainly you can go to the American Cancer Society website and potentially try to search that term. I think those are great resources. But yeah, no, I'm not familiar.
I want to piggyback on what she's saying. I have a friend who's working for the government, and he said those reports were buried because it works better than chemotherapy. And I am Caribbean, people drinking, and most people vouch for it. They say that it's helpful on some levels. They've used it personally, and they cannot reproduce what the fruit offers in terms of getting FDA approved. So I don't think it will be. It's an original state. It has to be consumed, and where they found it, where they went to research and found its natural state, they can't find a way to reproduce it into a supplement that it can be FDA approved. The other question I have is, when I had my surgery and my tumor was removed, and I had to sign something saying if I, would want this to be used in research to be helpful to people, and if I would want to receive a phone call back if they found new developments on tumor, and I said no, because I'm like, I'm done, at that point. But what are the pros and cons of that? Because I remember reading a book about Henrietta Lacks, where her cells constantly reproduce and are still living, so they're being used for testing, and the family, went to the forefront of the government to see if they could receive some type of benefit from that. I'm not really interested in benefit, only that it will help people with research, but what are the benefits for me to get information? Because I didn't want it, because I don't want to have to be living with knowledge about, to me, knowledge, sometimes ignorance is bliss, because you get too much knowledge, you're worrying in your head about it, but I want to know what would have been like pros and cons in terms of having your cells or tumors be involved in research and that you get information from it.
So I think great question. And I do want to circle back to the soursop also, just to talk more about integrational medicine. But I think it really depends on how you're wired. I think, and that's why I can't emphasize enough a personalized approach. So some women feel empowered with that information. They want to know anything that's found. Potentially the pros could be that it could potentially be a finding that could impact your children or the next generation or your siblings. But as you said, it depending on how you're wired, it could also be something that could just drive you crazy and not let you have any peace. So I don't think there's any guilt in that decision. Great that you signed the consent to I guess it was for a tissue bank probably, for them to be able to look at your cells, and that's probably the easiest research to sign on for, because you don't necessarily have to learn any of the data or what have you, or how your cells will be used. They'll be using it potentially to test different drugs or what have you, and potentially not to look for any other genetic mutations or defects. Bringing up the HeLa cells, I think is great. I think the awareness around the HeLa cells is great, and it kind of goes back to what I was saying about clinical trials and just the distrust that sometimes there is in the medical community in terms of how your cells will be used, who will profit from your cell line. I think there were quite a few Supreme Court decisions around the HeLa cells, and now I think it's incredibly difficult to profit from that type of research. Well, obviously, drug companies are profiting when they discover something, but they're also putting millions of dollars and resources into research and development. So I don't think there's a right answer. We always want, if there's a clinical trial open for a specific disease, I don't know if it's just the way that we were taught in med school, but we typically want our patient to be enrolled on those trials because one, it answers questions, but two, it potentially may give you a better option than what the standard of care is at that time. We're trying to figure that out. That's what we're trying to establish. Or it may be equivalent and just a wash, which is okay. But it takes so many years for the research and development to get done. So I don't think, even if you had said, please contact me if you find anything, I think you can breathe easy because there's nothing to say that your cells would be used potentially for genetic testing or what have you. And it just takes a really long time to find these different discoveries. In terms of soursop, which again, I don't know anything about, but what I will say is that you are seeing more and more of these different academic centers using integrationists. So they're looking at vitamin D, they're talking about obesity, they're looking at different factors that potentially can also impact your prognosis or your risk or your development. And they really are starting to do a good job or a better job at marrying Western medicine to these more integrationist techniques that potentially wouldn't have been considered years ago. So I always keep an open mind, but if there's no data in front of me, because what we always want to do is practice evidence-based medicine where the data drives the treatment. If there's no data in front of me, I tend to steer away. But that being said, you never know.
Thank you so much, Dr. Andrews, for your input. I have a question. Is there a connection between radiation of the left breast and heart disease?
So that's a great question. Certainly, I would say that 20 years ago, when our techniques were a little bit more basic, you could definitely see more cardiac disease with radiation. Radiation, we're not intentionally treating the heart, but the heart is beating up against the chest wall. So as much as we try to block out the heart, we can't block out the heart completely. What we do is make sure that we are treating the heart below the tolerance dose that we know the heart can sustain from radiation. There have been many trials kind of going back and forth on this issue in terms of whether or not radiation increases the risk of cardiac disease and left-sided lesions. And for the most part, it's still controversial, but what I will say is many of the studies show that if you have a history of cardiac disease, then certainly radiation can increase your risk of developing worsening cardiac disease. If you don't have cardiac disease, you may potentially not develop cardiac disease down the road. That being said, our techniques and our advances are looking at ways to further minimize treatment to the heart. And so what you're seeing is more places looking at prone breast radiation, where you're lying on your stomach. And so your breast is hanging away from your chest wall, so there's less dose going to your heart and your lungs. They're also looking at things like deep breath inspiration, where you're being treated at a certain time, at a certain point in your inspiration, respiration cycle, expiration cycle, where we know that your heart is being pulled away from the chest wall. So we're still looking at it, we're still addressing it. We want to minimize toxicity to any of the critical structures that should not be treated. But the data, I would say, is kind of in the middle. It says, unless, if you do have cardiac disease, then yes, potentially we can worsen it. The techniques that we use, a lot of times we use something called intensity-modulated radiation therapy. And basically what that's doing is we're telling the computer, I need to treat this left breast. I need to give a nice even dose distribution to this breast, but I need you to spare as much lung and much heart as possible. And the computer then runs a bunch of trials to figure out how to do that and come from all sorts of different angles to block out as much normal tissue as possible. So it's certainly something that we are cognizant of. I would say the data is still being, still kind of goes back and forth. It depends what institution has published it, but it's definitely something we are working towards minimizing.
Hi, Dr. Andrews. I am an 8-year breast cancer survivor. I wanted to comment, not really ask a question. I am suggesting, besides talking about tumor size and the lymph nodes, and in terms of stages, you also should tell a woman or a man who's diagnosed with breast cancer whether it is triple negative or otherwise, because I had to go to 2 different breast surgeons, and the second one told me whether it was, that it was triple negative, and not only that, he did a BRCA gene test, which came back negative. But the interesting fact about it was that my mom was diagnosed with breast cancer and passed away in 1979, and then I got breast cancer in 2007. So, I learned a lot going to 2 different people.
So let's talk about triple negative a little bit, because I think it's relevant, and I think there's a lot of fear around triple negative. Basically, what triple negative breast cancer is you don't necessarily, the breast cancer cells don't have estrogen, progesterone, or HER2 receptors for us to be able to treat you with those types of targeted drugs like tamoxifen or Herceptin. Triple negative breast cancer has to typically be treated with different chemotherapy combinations. Not all triple negative breast cancers are aggressive, but they do behave differently in that triple negative breast cancers tend to have a higher recurrence rate within the first 3 to 5 years after diagnosis, whereas estrogen receptor positive breast cancers, potentially you'll have a later risk of recurrence, and have late recurrences, but certainly it's relevant, but I think there's a lot of fear around triple negative breast cancer. I think there's a lot of research being done on triple negative breast cancer, and the difference between triple negative breast cancer and estrogen positive or HER2 positive breast cancer is just that we don't have specifically targeted therapies for that cancer. We do have chemotherapy, we do have an arsenal that we know works, but we don't have a specific drug that will further decrease your risk of recurrence.
That's why the triple negative female, that's why they keep them right away.
Say it again?
I friend of mine was diagnosed with it, and she was treated like right away. I was saying quicker, like they try to get to it like more quickly. I would say like,
Quicker with the chemotherapy, or
Yeah. Like they say, they
so let me see. Like for instance, maybe if you were estrogen or progressive, I can't say it. Positive, they would treat you, like when it's time, but with triple negative, they wanted to get to it. That's
I don't know the specifics of that case. Certainly what I can say is that if we're talking about neoadjuvant chemotherapy, starting with chemotherapy as opposed to surgery, sometimes that's done in effort for breast conservation. If a patient has a larger tumor and they are interested in preserving their breast, we may try to shrink it with chemotherapy first. Sometimes it's a locally aggressive cancer where the medical oncologist is really trying to help determine the biology of that cancer, see if it does respond to chemotherapy. So there's lots of different reasons why we do neoadjuvant chemotherapy. It doesn't mean it doesn't necessarily mean that it's because it's triple negative. Estrogen receptor positive patients can get neoadjuvant chemotherapy also.
Hi, thank you, Dr. Andrews. I'm here in support of my friend Clara, who's 40 years old, just recently diagnosed, and we're trying to find the path. So my question is she's at a point that we're going this coming week, next week, for her first consultation for chemotherapy and radiation. Both. She has one lymph node involved. So the question is, I'm trying to be concise, with a second opinion. So as a 40-year-old woman with a ER positive, the progesterone positive, and HR2 negative, is there a second opinion of what, say, the first step now with the one lymph node, chemo, it raised her to a stage 2. So that, I think we have a handle on that. But is there a second opinion on what the chemotherapy? Is there different opinions of how one oncologist versus another what her cocktail, what her mixtures will be? You know, what questions do we start with? Because, you know, we're amateurs here.
Sure, right. If you've never had to deal with it, what questions would you know to ask necessarily? What I will say is thankfully, there's been a great deal of research done on breast cancer. And so, as I was saying before, when we are doing things, even with the Crohn breast cancer treatments, it's because we've already tested them on trials and what have you. So with chemotherapy, there's a big breast cancer meeting every year, the San Antonio Breast Cancer Symposium, as well as ASCO, which are the clinical oncologists, and they look at the newest developments in terms of chemotherapy, whether or not to keep you on tamoxifen for 5 years versus 10 years. Certainly, depending on where you trained, depending on your friend's pathology and different prognostic factors that they saw when they removed the cancer, she may be a candidate for one chemotherapy over the other. I think that's when you just have to ask the hard questions, right? And you have to ask, you know, what will the side effects of this chemotherapy be? You know, what is my risk of recurrence if I don't take the chemotherapy? And you have to ask the questions till you're comfortable. You won't, certainly the physician should spend time with you and make sure that you understand why they're offering one chemotherapy option over another. But in terms of, I think a second opinion is valuable because you'll want to know if another oncologist would offer the same chemotherapy. But that being said, if they don't, it doesn't mean they're wrong. It's as much of an art as it is a science, but we are all following templates, so to speak, in terms of the data that's been established. Now, if you have a medical oncologist that gives you, kind of a cocktail that's never been mentioned, then probably your comfort zone is not with that physician, right? If they're not able to necessarily quote the data behind why they want to use those regimens, that may not give you as much comfort as a physician that can tell you, based on these trials, we know that for younger women or premenopausal women with node-positive disease, you may benefit from this chemotherapy regimen. But it's kind of like going to a lawyer, right? You have no idea whether or not, when you're going to a lawyer, whether or not they're giving you good advice. You have to go to a reputable place that has a strong background. And typically you also follow the referrals of your surgeons or your radiation oncologists. Most of these people work together, and certainly if one link wasn't as strong, they probably wouldn't continue that relationship.
Right, that's what I thought. And one last question. While she's awaiting the results of the BRCA gene, which they finally agreed to have it tested, will the results of the BRCA gene, what would that change regarding her treatment? Because she had not started treatment as yet.
So I think it's a personal decision. What do you do with that information? If you find out that you're BRCA positive, how do you feel about that information? Do you then go back and have a mastectomy? Do you then go back and have bilateral mastectomies? I think it's good to talk to a geneticist at that point. But you don't have to make any kind of knee-jerk decisions. It's just good to accumulate the information. And then I'm a very big believer in going to the people that specialize in those different areas. So any patient of mine that has a positive BRCA test, I'm always making sure they get to the geneticist. If there's questions about the chemotherapy, either I'm on the phone with the medical oncologist or I'm sending them right back to the medical oncologist, because it's key. I don't want to sound like a broken record, but it's key that you understand what we're doing and why. Especially as you move down the road into survivorship and potentially certain issues will arise, you need to be able to look back over the records and say, well, this was done then, and it was done because.
Thank you. That's immense. Thank you.
Hello, doctor. I had surgery last January, estrogen positive and 1 lymph nodes. I went through 16 radiation. I've been asked to have chemotherapy, and I'm on a pill a day. I can't pronounce it. Yeah, right. Now, do I consider myself a survivor, or do I wait 5 years to call myself a survivor?
I love it. I love it. I think you're a survivor from the minute, you're diagnosed, truthfully.
I tell you, it's soon I found out I had cancer at Christmas Eve, and I didn't bat an eye. I went with my son. I'm with him for 20 years. I went with my son with Dr. Maurer right away, have it done, take it out, Dr. Maurer. A year later, I'm like, wait a minute, I'm a cancer person. I have cancer. And for a whole year, I had all this done, and I didn't realize that I had cancer.
Sure. Yeah, no, it's not uncommon when you process it, how you process it. You don't necessarily process it up front, but it sounds like you handled it beautifully and you didn't skip a beat.
I did. Right. Thank you. Thank you so much.
Any other questions?
When I was originally diagnosed, back in 2001, I was, they had stages and grades. Now they have stages in letters and numbers. Can you tell me the difference? I was stage 2, grade 3. What would that be today?
The same.
It would? Oh, okay. So what's the T numbers and?
T is the size of the tumor.
Okay.
The N, so the stage is T, N, M. T stands for tumor, N stands for nodal involvement, and M stands for metastasis. So you are a stage 2, so a T1 or T2, N0 or what have you. When they're looking at the grade, that's basically what the pathologist is looking at under the microscope. So that's what the pathologist is using to determine how well behaved or aggressive is your tumor. And grade 3 is a relatively aggressive tumor, so your treatment was probably relatively aggressive. If somebody is a grade 1 versus a grade 3, premenopausal versus postmenopausal, estrogen receptor positive versus triple negative, it leads you down different algorithms for that patient's treatment options.
I guess my question is, why did they change the formulation, if you want to call it that?
They didn't change it that much. So it's the AJCC staging. And I remember they changed it when I was a resident, and then they came back, I think, in, gosh, I can't remember when it was, maybe 2007 or 2008, when a new manual came out. Certainly they do make changes in terms of whether or not, the changes that they make are typically minute. So the staging for breast cancer didn't change substantially. It was always the TNM staging. Typically when we're giving your stage, we document whether you're estrogen receptor positive, HER2 positive, your grade. Where you might start to see the letters is if it's a T1A, N2C. That's just more nuances of the staging manual, but it's not different necessarily.
Anybody else?
Well, I want to thank Dr. Andrews so much for coming out and speaking. And I see a lot of new faces here too, so I wanted to make sure you knew about us. We have a hotline that you can call, like we were saying, with over 100 volunteers who are survivors who can answer questions and be support for you with anything. And the number's right here. It's 1-800-8. It's probably not everything that you picked up on that table. If you need it, it's out there. And we also offer professional support systems as well. There's social workers, including myself, who will do individual counseling if you feel like you need someone to talk to. And we also run different support groups. So you can sit with a group of women. One of the support groups is here, in fact. You can sit with different women and talk to them and get information that is more supportive than you could ever imagine. And there's always a social worker there as well. We have outreach programs. We have a social worker out at NUMC. Any questions you have, please feel free to ask me or anyone in the room. Can you raise your hand if you're a volunteer or staff, so in case people want to ask questions. So if you have any questions, just feel free to ask us and call us. Keep in touch. We're so glad you're all here.
I also wanted to add, just in my own experience, I give so much kudos to the volunteers. Certainly while you're going through breast cancer, you're going through the ranges of emotions, but for a lot of breast cancer survivors, it is not only rewarding but cathartic to become a volunteer and to help another woman get through that process. And so I think it takes a special person to do that. But you will all get past it, you will all regain your lives, and it's just how you want to move forward from there.
I do want to say that we also want to support others. So even when you're never going to give up,
Adelphi also runs a support program. So we answer the phone if you have the question, and we will follow you, but we will also recommend you join a group. It's not for everybody, but it could be for you. And then you have other women in the same position as you are that you can talk to. And in doing so, you can talk to people who are not tired of hearing the same thing over and over. You can voice your fears without getting anybody else upset or involved. And it's a wonderful experience, and they do a wonderful job.
Thank you so much for coming, and I hope to see you all soon at our next event. Thank you.